I mean, people will remember that before all of the combination trials started, I would say before Chris Sweeney revealed the result of CHAARTED, it was very common to recommend intermittent androgen deprivation therapy, meaning pausing the hormone for a while in patients with a very good PSA response. We had very good data showing that if you reach a PSA equal or more than 0.2, you're probably a very good candidate to intermittent androgen deprivation therapy. Then all of that disappeared because all the trials were registration trial, patients were treated until progression. And even in the label package, it's like, it technically, we don't speak about that anymore. What we speak about is continuous treatment. Now, when you look at this trial, you can make two observations. First, patients live much longer, and thus they are exposed to more toxicity. And we see rapid increase in cardiovascular toxicity, falls and fracture, and cognitive decline. And at the same time, these studies show that they significantly increase the proportion of patients who reach 0.2 or less, and that these patients have a super prolonged overall survival. So really, it raised the question, should we revisit the role of intermittent androgen deprivation therapy in these patients treated with combination of novel treatment who reach a PSA of 0.2 in between 6 and 12 months? I really believe this should be done in clinical trial first, because we had clinical trial before. They were never really conclusive. So if we don't do a good clinical trial, we're still going to discuss, should we do it for 10 years, with a risk that we either overexpose or undertreat patients. So that's why at EORTC, we're starting this trial, De-Escalate, which is sponsored by the European Union, that will revisit that question. What is the risk-benefit of stopping the treatment in patients who have an extensive PSA response? But I believe that's a very rapid way to reduce resource utilization, improve the quality of life, and save the patient from some side effect. But whether this should be done in the practice today, I would say, with the exception of patients who would have severe toxicity to the treatment, I would not recommend that before the clinical trial.